Another interesting regimen that was developed there builds on the use of inotuzumab. So inotuzumab is the antibody to CD22 attached to a toxin, which is calicheamicin, and some people might recognize that because that was the toxin in Mylotarg, the drug that was an anti-CD33, so a different antigen antibody, but was originally approved before it came off the market in AML. So here we have the target being CD22, which is ubiquitously expressed on ALL. And in fact, the relapse trial was comparing inotuzumab versus chemotherapy or standard of care. In relapsed ALL, that trial was recently published in the New England Journal of Medicine, and there's a very strong belief that any time now, within the next potentially month or two, that will have an FDA approval for relapsed ALL. So just like with blinatumomab, and this is happening with blinatumomab, if you have a very effective salvage regimen, ideally you'd like to move it up earlier, right? Because if you can get good results in relapse, you might get even better data if you can get it into a better population of frontline patients. So this is a trial that was designed specifically for older patients with ALL, so over the age of 60, where it uses the Hyper-CVAD base, but there's no anthracycline because the inotuzumab is added in, and the chemotherapy doses are dramatically reduced. Again, the older patients were targeted because it was felt that they would benefit the most by having reduced chemotherapy doses, because in older patients, often relapse is not the major problem, it's actually death in remission because of the toxicities and the difficulties of trying to give multiple cycles of myelosuppressive chemotherapy to an older population with ALL. So that was the design of the study. It was a phase 2. And what they have shown is that the MRD negativity rate, and just like in pH-positive ALL, in non-pH positive ALL, that's also the most important determinant of outcome, is very high in that trial, on the order of about 60–70%. And when they compare the data, they did have deaths in remission, so again, still with chemotherapy, that can be an issue. But when they compare the survival data, which is about 50%, to the historical survival data, again with Hyper-CVAD alone, without the inotuzumab, it goes from about 30-something% to 50%. So dramatically better. Again, not a randomized trial, but comparison to historical controls. So in comparison to the historical control data with Hyper-CVAD without the inotuzumab, the long-term survival there in the older population was on the order of low 30%, and now with the reduced chemo dose, but with the use of inotuzumab, it's up around 50–55%. So this appears to be significantly better. Again, it's not a randomized trial, but significantly better than Hyper-CVAD at full dose without the use of inotuzumab. So that's very interesting data, and again, one of the first trials to try and incorporate an agent that probably any day now will be approved for relapse earlier up into a frontline setting. One thing they did notice is that there was some significant cumulative thrombocytopenia, and we know that inotuzumab causes thrombocytopenia, so another revision to the protocol was to lower the inotuzumab doses, and that trial is actually continuing with lowered inotuzumab doses.